Because IFS has recently gained so much popularity, there's been a lot of discussion around whether or not it is safe and scientifically grounded, which is totally fair. The more widespread something becomes, the more important it becomes to make sure it is legitimate. So throughout this series, I'd like to offer some of my thoughts. Now, I'm going to come down on the side of IFS actually being quite scientific, maybe even cutting edge, and safe, at least safe enough for most people, and we'll talk about those two caveats. That being said, the discussion around what is scientific and safe, not even related to IFS, but just in general, is really complex. So I hope you don't feel like you need to agree with my position by the end of this whole series. And yes, this conversation will need to happen over a whole series of videos, because there is indeed quite a bit of complexity here. But my hope is that we can just grapple with some of the complexity together, and then you make up your own mind. So let's dive in. In this video, I want to address whether IFS is safe. But before I do that, I was really intending to include in this series, and would still like to, a video on whether IFS is evidence-based and whether that even matters. The truth is, I didn't have time to write the script before recording today, so since I'm not going to have the chance to record again for a while, I just want to make a few comments here. Here's the thing. If you define evidence-based by the official definition given by APA, then yes, it matters. And yes, IFS would be considered evidence-based. According to APA, there are 3 pillars to consider when judging the level of evidence: best available research evidence, clinical expertise, and patient characteristics, culture, and preferences. So APA's definition of evidence-based paints a really holistic picture when it comes to assessing the scientific and practical validity of an intervention. However, most of the time when you hear the term evidence-based, people mean, does it have at least 10 or more randomized controlled trials, or RCTs, of which IFS only has 1? But that question only focuses on the first pillar, research, and only one version of the first pillar, RCTs, which you could absolutely argue are the least clinically helpful. There's a lot I could say about why, but I want to keep this short, so let me just point to something called the dodo bird effect. The dodo bird effect is the term researchers use to describe the fact that when it comes to meta-analyses that aggregate all the passing RCTs, no one type of therapy has ever performed better than any other of the ones we've studied. I mean, what? This might surprise you if you've heard that CBT is the most evidence-based treatment. In truth, CBT has literally never outperformed any other model of therapy it's been compared to. This is a well-known fact. There's a very official statement by APA that outlines this finding that all the main therapy models get equal outcomes. Now, there are certain exceptions, particularly when it comes to severe anxiety, especially when it manifests as phobias or OCD, because those do indeed seem to respond best to certain kinds of interventions. But by and large, the dodo bird effect has reigned. And trying to explain that fact has sparked what is called the great psychotherapy debate. Now, Bruce Wampold is probably the most informed voice in this debate, and he believes the dodo bird effect comes down to the fact that most of the impact of therapy is due not to the type of therapy used, as long as there's some cogent path up the mountain, but rather to what are called common factors. In other words, it isn't so much about the specific techniques themselves, but more about general factors that can be part of any type of treatment. The most famous common factor is the relationship with a therapist, but there are other factors as well. Now, I actually personally go a bit against the grain here, because even though I absolutely believe in common factors, and seeing how IFS actually supports all the common factors is one of the reasons I love it, at the same time, I'm a believer that we should still be looking for something called specific factors. I think if we can find some specific techniques, like parts work, that actually seem to make a powerful difference themselves, then we could possibly invent models that are more effective than what we've had so far. But here's the thing. Most of the clues that will be helpful in guiding that endeavor won't be found through RCTs, at least not the traditional kind. Now, there is a group of third-wave CBT therapists, most famously Stephen Hayes, who developed ACT, who just recently have started trying to reinvent randomized controlled trials to finally ask questions that are clinically useful. They say, look, we've been asking the same old question, which therapy is best? We've done that for 50 years with almost no useful data coming out of it, which may explain why we haven't improved our outcomes as a field for 50 years, which is a big deal. It might just be time to ask better questions. Now, there are many better questions that people like Norcross and others have already been asking, but one of the most important questions that Hayes is pointing to is not what kind of branded therapies lead to better outcomes, but what kind of therapy processes lead to better outcomes. That's a much more granular question, and that kind of research could actually help us improve our therapies. Until that research comes in, we can still create new therapies or even evaluate new therapies like IFS. How? Well, we can look at the 50 years of more old-fashioned process research we have. Process research is often overlooked, but really useful. We might get clues through looking at the brain and understanding what triggers different types of neuroplasticity, like memory reconsolidation. I think we should talk more to clients and gather qualitative data and get feedback. We can use case studies. I think we should study therapeutic responsiveness, which is about tailoring treatments to the individual. That's what Norcross has been leading the charge on. I think there's so much work to be done. And while we are doing it, should we do a few more RCTs on IFS? Yes, because it's become really popular. And I think people will want to see the preliminary data replicated. And I actually think there's a good chance that IFS might beat the Dodo bird effect. That being said, for reasons I won't go into now, there's almost no chance that IFS could possibly perform less well than the treatments we've already studied. If you want to know why I say that, I'll link to an article below by my mentor, Bruce Ecker. That article will also outline why I think we shouldn't give up on specific factors just yet. But now to the topic of this video, which is around whether IFS is safe. And that is a bit of a more interesting question. Because while we already have the data that would allow us to predict that IFS would likely perform as well as other treatments and outcome in the light of the dodo bird effect, that isn't the same thing as saying it is safe. That being said, we don't have a lot of good data on any therapy in terms of safety because it is really hard to measure negative effects from therapy. Now, we do have some data, which isn't all that reassuring about therapy as usual, which we will talk about later. But when people say we need to research the safety level of IFS, I just want to mention that how to do that, at least with any accuracy, is not completely straightforward. We'll continue that track later, but for now, let's look at the question, is IFS safe itself? It's a question that sounds really simple, but actually invites exploration of a few more complex questions, including whether perfect safety in our growth work would even be a good thing. There are pros and cons to taking risks in therapy, as in life. Now, I don't mean to say no pain, no gain in some kind of flippant way. I think we need to make therapy as safe as we possibly can. I'm constantly thinking about how to optimize safety in therapy because it is so important. That being said, I don't take 0% risk as the goal because 1, that's just not realistic, and 2, if we did take that as the goal, we just wouldn't do anything, and that actually also comes with its own risks, as we'll talk about in a later video. A better question, at least in my mind, is how much is the client at each step given a choice around how much risk to take? Of course, if they're going to make an informed choice, they also need to have a clear understanding of why they might want to take risks in terms of opening up painful material in the first place. We will explore that why more in a later video, why go deep in therapy. But let me just mention one thing here, which is that one of the most powerful common factors that I was mentioning is around the client confronting what has been previously avoided. Now, CBT does this through exposure to phobic stimulus, which definitely can come with some risks. Emotion-focused therapy does this through confronting avoided emotions. Many trauma therapists will have you confront old trauma memory. There's just something very important about seeing we can face any aspect of our experience or life head-on without it crushing us. That can lead to a sense of mastery, which is another well-researched common factor. Okay, so we know from the research that mastering something that has previously seemed too much for us is an important part of our growth and healing, so it probably won't surprise you to hear that pretty much any form of therapy will carve out some space for taking risks, which is likely why every therapy, even evidence-based therapies, have already been shown to potentially cause harm. Although, as an aside, when clients are asked what they feel harmed them in therapy, it really isn't typically the therapy technique, but usually the therapist, especially when they perceive the therapist as rigid or dismissive or blaming. And obviously, when it comes to that kind of unnecessary interpersonal harm, the goal would be to minimize it as much as possible. We'll talk about some of those nuances in a later video, but the first point I wanted to make here is that risk itself isn't necessarily a bad thing. But does that mean the risk-taking aspect of therapy should always be incorporated? No. When someone is in psychological crisis or experiencing more severe psychological symptoms like psychosis, the aim should be stabilization. A perfect example of that would be during the acute phase of an eating disorder. Why? Because when the person's brain isn't even getting enough glucose to function effectively, there's no way it can be resourced enough to safely engage in challenging inner or outer work. Now, the example of eating disorders likely came to mind because of an article that came out describing harm done to a group of clients who were being treated inpatient for eating disorders, but sadly, instead of being stabilized, were put through all of these regressive techniques that also sadly were called IFS, even though IFS is almost obsessively non-regressive, which we'll talk about in a later video. Okay, so I'm mentioning this article because it promoted the idea that IFS is dangerous. Now, I actually did think it raised one or two important questions around safety, which we will get to. But first, let me vent a bit about how unethically this article was approached, because I do think some people were really destabilized by what it said. I went into it with a totally open mind, thinking, okay, maybe this author did a study on IFS, or at least consulted with a panel of IFS therapists, or interviewed a random array of IFS clients, or tried IFS themselves. But no, they didn't do any of those things. They mainly just took one really scary story about this group of clients that I mentioned, who were all under the care of one seemingly abusive therapist who ran this apparently awful treatment center. And since this person said they were doing IFS, which from what was described they clearly weren't, the author of this article drew the conclusion that IFS is some crackpot theory. They even suggested that IFS is not accepted by the scientific community, which on the face of it is just a bizarre thing to say. I mean, it was literally on the National Registry for Evidence-Based Programs and Practices as one of the official evidence-based treatments. Now, that registry has since been closed for contentious reasons that get to the heart of the debate around how closely therapy needs to be beholden to the medical model. As I began to explore earlier, our field is really facing some important questions, not around whether we should be scientific, but how to be. How well do we fit the medical model? Now, I'm a believer that our first attempts to fit the medical model showed that we don't fit it that well. Remember earlier I mentioned that we haven't been able to improve our results as a field for the last 50 years. Think of the gains medical research has made for us in the last 50 years. If we fit alongside that model perfectly, we would have made gains as well. So many of us think it's time to pause on the track we've been on and try to be creative and find new options. But someone else could totally disagree. You will hear conflicting accounts of just about anything because the science of psychology is really complex. But needless to say, there are plenty of respected researchers and professors who are excited about IFS. But let me come back to the fact that this particular group of clients were indeed harmed by something that, while in practice was not following IFS protocol, was being marketed as IFS. I don't want to minimize that, particularly given that the therapist in question had the stamp of approval or was at least trained by Dick Schwartz, the person who invented IFS. I do find that a little alarming. On the other hand, I don't necessarily know if it's fair to condemn Schwartz for not sussing out that this guy was horrible, given that I know how people can be really misleading about who they are. If you've been watching any of these documentaries that have been out recently on cults, you'll know what I'm talking about. From what this article described, it sounds like this particular therapist, also confusingly named Schwartz, was being pretty darn culty and doing all sorts of unethical things. I say all this to point out that it's one thing for a client to be harmed because their therapist is harmful versus because the therapy model itself is harmful. In other words, there's a difference between side effects of treatment and malpractice. But while we are here, let me define a few terms used in the research. We have what is called deterioration, which is when a client ends up worse after therapy, but we don't know why. It could be due to something happening in therapy or happening in their life outside of therapy. When it's due to therapy, which can be hard to determine, we split it into two different categories. We have the iatrogenic effect of the therapy itself, also called side effects, which is when a valid intervention inadvertently causes harm or deterioration without any sign of clinical error. And then we have malpractice, which is when harm is done because the therapist actually made a gross mistake or did something unethical. So obviously why I was disappointed with this article was because it took malpractice and confounded it with the idea of dangerous side effects. The reason it was frustrating to see IFS of all therapies being pegged as unsafe is that I've rarely seen a form of therapy as obsessed with safety as IFS. The most common complaint I hear about IFS from clients is when they tell me that the protocol feels a little too safe. Their therapist is just letting them hang out with their protector parts, i.e. defenses, and it isn't going deep fast enough for them. Now, that's not always the case. I've had other people tell me they felt destabilized by even just attempting to access their inner world and their parts. Beginning to explore what's inside can indeed be a treacherous step, but that goes into some of the pros and cons of trying to go deep, which we'll explore more in later videos. That's probably an even more interesting conversation. But let's focus first on what was raised by the article, because as I said, it did raise a few red flags that just haven't taken up much space in my mind. So maybe it's not bad to look at them. One of these red flags was the danger of clients being guided to remember a false memory of abuse. To be honest, that particular concern had sort of fallen off my radar, which is weird because the danger of false memories was something sort of seared into me during my childhood. You see, both of my parents were psychodynamic therapists during the late 80s, early 90s, when the satanic panic happened. And to a kid, that's all pretty freaky stuff. Okay, so if you've never heard of this period, there were a few years there where every other therapist seemed to be reporting that their patients were remembering ritual abuse. Not just abuse, like cult ritual abuse. I remember this book that my parents brought home called Michelle Remembers, and it had a girl sitting in the dark with candles all around her. And I was like, oh, that book is scary. As it turns out, it was that book that might have ignited this whole thing where therapists were expecting clients to report abuse, and so were then accidentally leading the witness, so to speak. In the end, there were well over 1,000 documented cases where people were reporting abuse that pretty clearly didn't happen. The FBI was involved. It was a whole thing. Now, there's still some lingering questions, but the take-home message was that therapists, in this case psychodynamic therapists, need to be really careful about suggesting abuse or even being overly excited or interested in abuse stories. This was definitely a cautionary tale that we need to learn from and not repeat. That being said, the take-home message was not that psychodynamic therapy itself was dangerous or a hoax, right? The danger was what the therapists were doing. So when I read this article on IFS, I thought, okay, but clearly this particular therapist was priming people to look for abuse stories, which he could have done while practicing any model. That being said, given that IFS has this moment where the client goes back in time to support a younger version of themselves and finally give witness to what was suffered, which honestly most of depth therapies have such a moment, but to stick with IFS, without the right training, an IFS therapist could begin hearing about past suffering and fall right into that old trap of influencing what is being revealed. And it would be as simple as seeming overly interested in certain kinds of gory details or stories. So given that that is the case, does the IFS Institute do enough to train people in how not to fall into that trap? I'm not exactly sure how to evaluate that. From my own training, I don't remember that specific danger being super emphasized. That being said, certainly the general stance of not imposing one's agenda or interpretations onto the client during their work is not only emphasized, it's practically the whole model. And most malpractice, including this version of it, comes when the therapist inserts themselves too much into the process or has an agenda even unconsciously. Which makes me want to reaffirm here what I love about IFS. IFS therapists are so carefully trained to let go of agenda, including the agenda to go deep. The protocol could not be more designed to be gentle and careful, even around any pressure to reveal something to the therapist. In fact, when the client goes back to bear witness to their previous pain, the therapist tells them, look, this is between you and you. You don't even need to tell me what it is you're witnessing. If that feels exposing at all, just keep it private. I've actually never heard any other form of therapy include that step. But why not include privacy as one aspect of safety? Again, IFS therapy itself is almost a training in how to listen to and make choices that are respectful to and true to one's own system. Now, given what I just said, if you're confused by how that description aligns with the story in the article, I'm right there with you. I mean, the simple answer is that any therapist under any model can be a bad actor. That being said, why didn't Dick Schwartz, who apparently visited the center and even did trainings there, why didn't he notice what was going on? I don't know. I've never met Schwartz, so I can't really defend him. But I will say, whether or not Dick Schwartz is amazing, which I honestly don't know, I do know a number of core faculty, and they are among the most serious, ethical, hardworking, effective therapists and trainers that I know. But just to wrap up this topic, while I think the IFS Institute offers training that is very professional and well-crafted, I can't say for sure that the issue of false memories is emphasized enough. Maybe it should be more. Since I don't have a clear answer, I will close by reading what the manual says about false memories so we can evaluate the official recommendations on this topic from the Institute. Any psychotherapy whose goal is to heal rather than simply manage emotions will invite clients to explore their past. In IFS, we do this when we begin the witnessing phase by asking an exile what it wants the client to know about where in the past it got the burdens it carries. At that point, people often feel emotions, sensations, sometimes accompanied by images or memories. Most of the time, these come from events they knew happened but had minimized, or the impact of which they hadn't fully appreciated. Occasionally, they are new to the client and are events they didn't know had happened. When such memories implicate caretakers or others in abuse or criminal behavior, accepting them as real when they may not be can have tragic consequences. There is a danger that both client and therapist will accept as real memories that are distorted, inaccurate, or totally false. In contrast to therapies that make interpretations or hypnotic suggestions about what likely happened to the client, IFS has a strong advantage because we let the client guide us, so we don't have to figure things out from them, we don't have to figure things out for them, or have agenda about where they need to go in their inner world. Thus, as an IFS therapist, you should clear your mind of any presumptions as to what happened to the client so that your influence over what comes up is minimized. I think that's really important. You should also take care not to celebrate the arrival of or immediately accept memories that are new to the client if they do come. So at least on paper, I think that's a very valid approach. And given that I haven't heard any horror stories other than the ones from this article, I don't know that there's much reason for alarm. That being said, why not take this moment as an opportunity to remember a mistake that our field made 40 years ago and reconfirm never to make that mistake again? So if you are a therapist watching this, no matter what model you use, and maybe particularly with IFS since it can go very deep, occasionally faster than people expect, I want to encourage you to hold space for trauma in a clean way. I have a whole 3-hour Ethics of Trauma course on my website that goes over this in some detail if you feel like you need more. I'm mildly obsessed with the ethics of trauma work, which is honestly partly why I've been excited about IFS, because at least it seems to tick all of the boxes. Okay, so what was the second concern raised by this article? Well, that organizing our inner world into distinct parts might cause some people to develop multiple personality disorder. That's something I want to address, along with whether IFS might cause emotional overwhelm for some, which if there's any risks, I think that's probably it. But because those are both big topics, we're going to have 2 more videos on safety in IFS. Look, I'm really open to the possibility that because IFS is so designed around safety, that we IFS therapists might have overplayed our hands on that at times. Most of the people I hear from, and I hear from a lot of people, say that IFS is really working for them in a way that little else has. But not every report has been positive. And even though I've never dismissed those reports, I haven't done a good job of keeping track of them all and sort of organizing that anecdotal data in any way. So I plan to start doing a better job of that, because if we want to keep improving either on the side of effectiveness or safety, we really probably, above all, need to listen to and solicit honest feedback from clients. And while one person's report, for positive or negative, is not super informative, if we start seeing patterns, that is something to pay attention to. But to close, if you're thinking, well, if anything can ever cause harm, why just not do it? Why try to go deep in therapy at all? That is a question we will dive deeply into in a later video in the series, and that's where things get really interesting. I'm Dr. Tori Olds, and I really appreciate your watching.
Welcome, friend, come inside.
Hey guys, thanks for watching. If you found this video interesting, I would love if you shared it with a friend or a colleague. And if you're enjoying my channel, it would mean a lot to me if you could like or subscribe.